Welcome to the Early Diagnosis of Cancer and Cervical Screening webinar for non-clinical staff in GP practices. Today's session will be covering an overview of the early diagnosis of cancer, followed by looking into the signs and symptoms of cancer. Given the current context that you are all working in at the moment, it seems pertinent to look at the barriers for patients in contacting a GP and how your role is key to overcoming these barriers. We'll also be looking into the screening programs with a focus on cervical screening, what it involves, and how you can encourage patients to come in for their screen and provide information and support before or during these interactions. We will start with early diagnosis of cancer and what we are faced with in this current context. What this graph is showing us is that the number of new cancer cases is rising, with the total number of cases depicted in the grey line that is projecting upwards. More and more people will be diagnosed with cancer each year as we move forward, and this is due to a number of reasons. The simple answer is that we are living longer and the incidence of cancer increases with age. But there are many other factors that contribute to this, such as lifestyle, smoking rates, and obesity in the population. If this projection is accurate, there will be an increased burden on the health system, which could impact patient experience and outcomes. The figures emphasize the need to plan now for the increased demand we can expect to see if outcomes are to be maintained or improved. Given that we are faced with an increasing number of cancer cases each year in the population, it is important to reflect on current trends and whether we are diagnosing them at an early or late stage cancer. Overall, just over half of all cancers, so around 54%, are being diagnosed at an early stage. So that's considered to be stage 1 and stage 2. As you can see from the infographic, some cancer types tend to be diagnosed earlier than others. For example, if we have a look at breast cancer that's depicted at the top left over there, 85% of breast cancers are diagnosed at stage 1 and 2, whereas if you have a look at lung cancer, which is just below, only 25% of lung cancers are diagnosed at stage 1 and 2. It is worth reflecting on why this could be. Some cancers have more recognizable symptoms, like moles on the skin and breast lumps, whereas others have vague symptoms which can be attributed to multiple conditions, such as cough, fatigue, and weight loss. So currently, only 54% of cancers are diagnosed at an early stage, so it's worth looking at where these patients are going for their diagnosis. This infographic is there to just show us that, firstly, around a fifth of patients are being diagnosed through an emergency route, which is displayed in the bright pink box. And when patients are diagnosed in emergency, they are much more likely to be diagnosed at a later stage. This would mean that their prognosis or the outcome of their diagnosis is worse, and the treatment options become more limited and less favorable overall. Ideally, we want to have more people diagnosed via the dark purple and blue boxes at the top, which is screening, which is the dark purple box, and GP referral, which is the blue box. And this is so that the cancers that are diagnosed through these pathways are more likely to be diagnosed earlier. Currently, only 6% of patients are being diagnosed through screening, which is the preferred way of diagnosing patients for the screening programs that apply. So, diagnosing cancer earlier saves lives. There are multiple reasons for this, including that the cancer is less likely to have spread, treatments are more effective at earlier stages, patients are more resilient, amongst other things as well. Encouraging screening and having opportunistic conversations with patients who may bring up concerning symptoms are an important part of early cancer diagnosis, and you are all in a prime position to be that support in the early cancer diagnosis pathway. You are the first point of contact with the GP practice, and people tend to see you more than they see the GP, and they may be more familiar or comfortable to bring up anything concerning and in casual conversation, as you may have experienced personally. We will now move on to signs and symptoms of cancer so you feel more confident in approaching opportunistic conversations or talking about cervical screening. This is something for you to briefly reflect upon amongst yourselves, or if you're listening by yourself, maybe even jotting it down. But I'll leave this here for about half a minute so you can have a think. But ideally, what comes into your head when you think about cancer? What are some key words that sort of pop up? So, hopefully, you've pieced together some words that maybe popped up or some thoughts that maybe came to your head. And we'll just go through some of the common words, terms, feelings that sort of came up in previous sessions. So, fear, death, sickness, pain, sadness, chemo, why, what to say, feeling lost. So these responses were amongst many others in sessions that have been held before, which included things like terminal, family, change in lifestyle, uncertainty, difficult to communicate to family. And what you may have noticed, and maybe even have seen amongst the phrases that you might have written down, is that these all have negative connotations and reflect how your patients may feel when hearing about cancer or worrying about the possibility of it. But a lot has changed in the cancer world. So, just a quick question to reflect on. I'll give you about 10 seconds. But survival rates are now twice as high as 40 years ago. So, do you think that this is true or this is false? If you selected true, that would be correct. The cancer survival in the UK has doubled in the last 40 years from 24% to 50%. Just another question to reflect on. More than half of all new cancer cases are down to just 4 types. Do you think that this is true or this is false? If you selected true, that would be correct. So, having a look at the most common cancers in the UK, as we just saw, more than half of all new cancer cases are down to just 4 types. And the 4 most common cancers are depicted in this infographic over here. Most types of cancers are rare, so these 4 that make up more than half should be on your radar as they account for over half of all diagnosed cancers. And so these 4 are breast, lung, prostate, and bowel. These are now classified as long-term conditions and will become more prevalent in communities. You may also have noticed by now that there is a national screening program for 2 of these, breast and bowel. So, having a bit of a reflection on what are the symptoms of cancer. So, have a think about what comes to mind, whether it be from your patients, from family and friends, work experiences, or even campaigns and other awareness programs. I'll give you about 15 seconds or so just to jot down something or just have a think about the sort of symptoms that come to your head. So, having a look at the symptoms that have come up in previous sessions, these are some of the ones that people have mentioned previously. So, unexplained weight loss, a new mole or changes to an existing mole, unexplained pain or ache, blood in poo or urine, feeling short of breath, night sweats. Other ones include weight loss, fatigue, pain, change in bowel habit, and many, many more. Notice that there isn't necessarily a single theme that pulls them all together, but the key point is it unusual for you? So it's important to see if it, whether a patient finds that is something has persisted for quite some time, or it's not usual to them, or they're quite concerned about it. The key factor to take away is that if there is a symptom that's unusual, it is important to see the GP. So a key thing to emphasize is we know how important it is that someone seeks help, so the chances are greater to spot cancer early or in reducing their risk through lifestyle changes. So we're not saying that everyone can be cured. We know people can have an exemplary lifestyle and still get a cancer, but we are hedging our bets in our favor. And and it is up to the individual to let the GP practice know or let a healthcare professional know, but you can also facilitate that early interaction by picking up on anything unusual a patient may bring up with you and flagging it with the patient themselves, the GP, or a practice nurse at the surgery if need be, and making sure that if it's unusual for them, if they have symptoms that don't go away, that they do not delay in seeing the GP. So, something more to reflect on is why do some people delay going to the doctor with symptoms? And you may have experienced various reasons that are brought up in practice, or even just knowing your patients and things that maybe have deterred them from seeing a GP previously. So, having a look at here, what you can see is there are a lot of barriers present, which is why it is important to act. The barriers that brought up include things like difficulty in making an appointment, worried about wasting a doctor's time, and worried about what the doctor might find. Sometimes it's more logistical, like such as it's difficult to arrange transport, or could be a matter of confidence if they don't feel confident in talking about the symptom or in talking to the doctor. And so there is a range of things that might stop someone or delay someone from seeking help from a GP. And it so in your role, it is incredibly important to be able to know what some of these barriers are and what you can do to help as well, because you're in a really wonderful position to enable and empower the patient and give them the confidence that they do have a valid concern and that the GP is there to help them as well. So the conversations that patients have with you are invaluable, and also may be a source of much comfort for patients who may recognize you more or may be more comfortable to speak to you. So, in terms of how you can help to overcome some of these barriers within your role, there's a few different things, and we will cover this in more detail a bit later on in the webinar. But things that you can do right off the bat are looking into appointments and how accessible they are, making sure patients know if there are extended clinic hours or available appointments, advising the patient to call the surgery and actively giving them the number or the opening hours of the surgery, and being aware of symptoms when patients call. So, and there are resources available that can sort of help, or if you do notice that someone's bringing up something that is quite concerning to them that doesn't seem to be going away, flagging it to the GP at the surgery as well. So generally, if a patient has been experiencing unusual symptoms for more than 3 weeks, it's usually a good point to notify the GP to let them know as well as handing out physical resources, or in the current context, you may be sending more resources either through text messages or through the post. But this quote is by a GP called Dr. Ben Daniels. And what it highlights is that your role is so important because you do have the relationships and connections with patients to make an impact. You can recognize red flag symptoms in conversation and encourage people to come in to see the GP. You can encourage them to come for screening if they've missed their appointment. Some people just need a gentle nudge from a friendly face as a reminder. And so this is a quote from a GP which demonstrates the value of your relationships or patients for their health, their well-being, and the ability of the practice to achieve the best health outcomes possible for their patients. And so Dr. Ben Daniel says, Sue has been working at our surgery forever, and she seems to have a personal relationship with almost every one of our patients. She knows that Mrs. Walsh never makes a fuss, so if she requests a home visit, she really needs one. She knows that Mrs. Michaels needs to be booked into a downstairs room as she can't manage the stairs, and that when Mr. Chambers books in for a blood test, he needs a double appointment and a cup of sweet tea ready as he is prone to fainting dramatically at the mere sight of a needle. And this is all seems like small things, but they are massive in building that relationship with the patient, but also making them feel comfortable to share with you as well. So keeping this in mind, we will be having a look at the screening programs, and part of your role involves encouraging people to come in for screening. So we will have a look into this a bit further. There are 3 national screening programs in the UK. You may recall that breast and bowel were 2 of the top 4 common types of cancers in the UK, but another one that we have is cervical screening, which we will be spending more time on in this session. In terms of why we screen, the design of all 3 screening programs are so that they can detect abnormal cells or tissue changes at an early stage before anything progresses to a full-blown cancer. So you can provide early treatment to prevent a cancer from developing. Early detection means that for some cancers, there is a higher chance of treatment being successful, as we touched upon lately. And as we also mentioned, only about 5 to 6% are being diagnosed through screening currently. Screening is not for people who have symptoms of cancer. If someone has a symptom that is concerning them, they would need an investigation by the GP. Screening is for people who don't have symptoms, and it's to detect cancer early. So they're usually invited as part of a round of patients that are sent an invitation as part and parcel of the national screening programs. This is an overview of all 3 screening programs, looking at who is targeted and how often, as well as what is involved in the screening process. There are also national targets that should help determine where practices can improve or share best practice when reflecting on their approach to screening when looking at the data. So this information will be included in the slide deck that will be provided, but looking more closely at cervical screening. The cervical screening program is for women or anyone with a cervix between 25 and 64 years old. They're invited every 3 years if they're aged between 25 to 49, and every 5 years if they're aged between 50 to 64. And so currently the HPV screen is the primary test. So HPV stands for the human papillomavirus, and it is a common infection. So most sexually active people come into contact with HPV during their lifetime, but for most, the virus causes no harm and the infection clears on its own. However, in a small number of cases, HPV infection can lead to cell changes that can potentially progress into cervical cancer. So cervical screening is designed to help pick up those abnormalities early. The reason it's not offered to younger women, so women under the age of 25, is because cervical cancer is very rare in women younger than 25. And the changes in the cervix are more common in younger women and more often than not go back to normal without treatment. So screening tends to offer more harms and benefits for women under 25. So that's why the age range sits between 25 years old to 64. Having a closer look at cervical screening, firstly, what we'll do is we'll briefly just touch upon the symptoms of cervical cancer and the sorts of things that that might come up. So things like bleeding between periods, bleeding during or after sex, bleeding after the menopause, change in vaginal discharge, or pain in the region. And women who notice any of these symptoms should see their GP straight away. They shouldn't wait to be screened. They should be able to see their GP. And just, yeah, as a reminder, screening is for women without symptoms. So if they do experience anything, that would be for the GP to investigate further. And we'll just briefly watch a quick video regarding the cervical screening test. So there will be a link provided to that video in the slide deck, and we'll have a quick look at who cervical screening is for. So firstly, cervical screening is for people aged 25 to 64 years old, as we mentioned earlier. It is for all women with a cervix, regardless of their sexual orientation. So this includes transgender men if they haven't had what's called a full hysterectomy. They can be self-referred, as people who are registered with the GP practice as male won't be automatically invited to the cervical screening program. It is also for women who have had a partial hysterectomy and the cervix is still in place as well. So if you are unsure, it's always a good idea to ask someone at the practice to maybe elaborate a bit further as well. Always ensure that women are making an appointment in response to the cervical screening letter and not because they're experiencing symptoms, because as we mentioned earlier, if they have symptoms, they should directly see the GP. So we'll just have a few things to look at in regards to the HPV, so the human papilloma virus, and just busting a few myths that do tend to circulate and that you might even get asked over during your practice as well. But firstly, 2 in 5 people will get HPV in their lifetime. So that's about 40% of people. And that is false. It's actually quite the opposite. It is very common. So common, in fact, that 4 in every 5 people, 80%, will have the virus at some point in their lives. This is why removing stigma around the HPV virus is so important. HPV is always something to worry about. Again, that is false. There are over 100 types of HPV, and the majority are nothing to worry about. However, there are 13 high-risk types of the virus that can cause cancer. Can, not will. So in most cases, if you or any partners you have get high-risk HPV, your bodies will be able to clear the infection, just like with low-risk infections. In a few cases, the infection can cause abnormalities in the cells of the cervix, which, if not detected and monitored, may potentially develop into cervical cancer. This is why it's important to attend your smear tests when invited so that any abnormal cells can be caught before they have the chance to develop into cancer. But looking at the next one, there's no relationship between HPV infection and smoking. And again, that is false. Smoking is actually a major risk factor for developing cervical cancer. So, if you smoke, your immune system around the cells of the cervix may be weakened, making it harder for the body to prevent and clear high risk HPV infections, which could cause abnormal cells to develop. And lastly, if you have the HPV vaccine, you can't get HPV. If you have had the HPV vaccination, you are protected against 70% of cancers causing HPV infections. However, you are absolutely not fully protected. Attending smear tests is just as important as if you have been vaccinated versus if you have not, as it will detect abnormalities caused by other types of HPV. So that is definitely false. So, as we were talking about earlier, there are barriers to people attending the cervical screening tests, and these are some possible barriers patients may experience in seeking that appointment, and it differs depending on the population group that you were looking at. So, for 25 to 29-year-olds, so the younger cohort, the barriers that do come up are things like embarrassment, body shame, fear, the risk of cancer, as well as accessibility. For women over 50s, some of the barriers is whether they think the test is relevant for them, their knowledge of the test, and unidentified risks. For women with a learning disability, things like health literacy, knowledge, and culture can have an impact. For BAME communities, again, health literacy, knowledge, the relevance, the culture, and potential stigma around HPV could play a part. For people who identify as LGBTQI, the relevance of the test may not be very clear. There may be issues around health literacy or an unidentified risk as well. And for women that have experienced sexual assault, there is a specialized need as well, and they may require the extra support during the process and in being educated about the test as well. So, the role of the GP practice is to provide informed information and resources and supporting informed participation and reducing the barriers to participation where possible. And so, as we had a look, some of those barriers could be the following: that they've never been before, they've heard it's painful, that they don't have time, they've always had negative results, so why bother? They've been vaccinated, so maybe they don't need to do it, and they may be a lesbian or transgender and don't think that they need it. And so what we have is, this is from the Cervical Screening Good Practice Guide, which we will provide a link to. But the things that you can do to encourage informed participation are making sure people are aware of the program and that it can help to prevent cervical cancer from developing, asking them if they have taken part and encouraging them to participate, even if their previous results have been normal, informing them about the benefits and harms of screening, and encouraging them to read the information pack carefully, or giving them additional resources or even access to the video that we showed you earlier, and ideally ensuring that any barriers to participation are minimized. So, things that you can do, or even reflecting upon what you're already doing. Firstly, having a look at opportunistic conversation. So, the Good Practice Guide has a telephone script that you may be able to utilize when calling patients regarding the cervical screening appointment. And the telephone script gives you various strategies depending on how that conversation goes, whether the patient is keen to participate, not sure if they're eligible or doesn't want to participate, and things that you can do to provide information, provide resources, and where possible, making it easy for them to book in for that appointment and encourage participation. There is also an SMS text template provided as well that you can use at your practice to send to patients who are due for a test. And these resources are all available in that guide as well. People may not be engaged in the program, so they might have never attended cervical screening, or they may be overdue their appointment. So some will also make an informed choice not to attend their cervical screening. So it's important that all decisions are respected and no one should feel pressured to participate, but they should also have access to information and resources so that their decisions are informed. So, overcoming the barriers and continuing to look at what you can do or what you're already doing and enhancing that and sharing best practice is increasing staff awareness about the program. So, part of that is done through this webinar here. But also raising awareness in patients about cervical screening. So, whether that involves actively reaching out to patients or even running campaigns. It might be worth appointing a screening lead in your practice for cervical screening. And you might do that as a PCN, you might do that as individual practices. Opportunistically ask women if they have done their smears, if they are eligible as well. And having posters, leaflets, easy read information, resources in different languages, or even things that you can send to people via a text message can be quite useful as well. Wide availability of appointments, so letting patients know when they can book an appointment for, and accounting for working hours, school pickup hours, and things that might provide a barrier to attending, and just being aware of your demographic and what would work best as well. Another idea that other practices have used before is to arrange for the practice nurse to show women the speculum before their first screen, or arrange extra support for those that have specific concerns. So even booking in a time slot for a patient to come in and have the opportunity to have a look at what is involved and be able to speak to someone at the practice without necessarily committing to the test at that appointment as well might encourage people to feel more comfortable. Furthermore, calling non-responders as well is quite helpful, because some people may have just forgotten as well, and having a regular practice discussion around non-attenders or non-responders, and seeing what you can do as a practice. And there are more suggestions provided, and we'll also be providing you links to more information should you need it as well. So there's quite a few things there that you can do, or that you might already be doing, that you can maybe tweak or enhance to help improve the uptake of cervical screening in your population. So before you walk away from the laptop or computer, try to make note of 2 to 3 actions that you will take back to the practice to assist in cervical screening uptake in your patients, or even increasing confidence in your staff in approaching conversations about cancer or cervical screening. It will have made the time that you have actively dedicated to this webinar be more transformative for you and your workplace as well. These could include starting an awareness campaign for cervical screening for a week each year, embedding the SMS scripts into your accurate systems, or actively reaching out to non-responders. In the meantime, thank you for listening. We have delivered this on behalf of the North Central and East London CRUK health professional engagement facilitator team. And the email inbox provided can also be access to help sort of provide extra support, or if you have any queries or questions, please do not hesitate to email that address there. Thank you for listening and hope you all have a good rest of your days.